Okay, good evening, everyone. Thank you for being here today at 6 p.m. and giving us your time. So this is our seminar number 2, Case-Based Learning 2, and this is from Group 3 and Group 4. So we have 1 hour to present our thoughts to you. So at the end of this seminar, we will be opening the discussion for everyone to share their personal experiences and opinions. All right, so let's begin. From Group 3, we have Dr. Madhya, Kamini, Dorothy, Suvarna, Darshini, Rosli, Aini, and Irene. And from Group 4, we have me, Huibing, Lumin, Freddie, Joanne, Kalila, and Victoria. So let us straight jump to the scenario that we've given to us. So this is it. You are the healthcare manager of an urban district of 3 million people. In this district, during a recent management meeting, you are concerned on signs of burnout among the personnel. And there were some changes to the annual assessment indicators for personnel performance. And you wonder whether this may be one of the factors. In addition, the overall team are still recovering and readjusting as the health facilities under your coverage area return to full daily operations following the pandemic. We are also concerned about the aspect of patient satisfaction with the healthcare services provided in your district. Prior to the pandemic, there was some unfavorable feedback received from patients on some aspects of the healthcare services, and you hope that this will not resurface. As a preemptive measure, you would like to look into these issues and find possible solutions. So now what we've done with this scenario is we've broken down it into 3 main things, which is first the signs of burnout among personnel. Then we have the annual assessment indicators, and we have the organization changing from pre-COVID to post-COVID, and also patient satisfaction. And we've divided this view into 3 pressures. These 3 pressures that could cause a person working in the district health center burnout. One is the individual pressure due to the indicators. Next is the organization pressure because of the change in the system, and also from the patients, community pressure. So our presentation today will be divided into 2 chunks. Basically, one will be talking about burnout. What is burnout? What are the types of burnout? How do we actually assess burnout? And what, as a leader, should we do to prevent burnout in our team? Secondly, we will look at patient satisfaction and how do we assess patient satisfaction and what characteristics the leaders need in terms of addressing patient satisfaction. Let me begin. All right, so burnout is something that we've all experienced. It's a work-related stress syndrome resulting from chronic exposure to job stress, and in the 1970s was defined having 3 qualitative dimensions. One is emotional exhaustion. Next is cynicism and depersonalization. And third is reduced professional efficacy and personal accomplishments. In fact, in the Medscape annual survey, the Physician Burnout and Depression Survey, they found that 37.9% of physicians are burnt out compared to the general population. And the physicians with the most burnout are the ones in the front line, such as family medicine, general internal medicine, and emergency medicine. Now, this was in 2002. And the survey revealed that emergency medicine specialists have 60% reported burnout. This increased from 2021, which was about 40%. Obviously, it's due to COVID pandemic and being in the front line. So what contributed to most of their burnout? Too many bureaucratic tasks, too many hours at work, lack of autonomy over their personal life, salary, increased computerization of practice, lack of respect from patients, government regulations, and stress that came from COVID-19. So if we want to address the situation, we would like to discuss about transformational leadership, which we'll be touching on later on, because leadership will assess these important factors such as stress, anxiety, and workplace loneliness, and will address the main issue of burnout. Now, before we begin with the first presenter, I would like you all to watch this video, and we will start off with our first presenter, Dr. Kamini. All right. Now, as we begin our presentation, I would like everyone to look at this discussion today from two perspectives. One is personal, from your personal experiences having burnout while working, and also from a perspective of the managers that you have worked with and how they dealt with it. So without further ado, let me introduce Dr. Kamini to take over. All right, Dr. Kamini.
Hi, thank you, Jonas. So I'm Kami here. So first I would like to talk about that there are many studies conducted to investigate the prevalence of burnout. So here are a few situational analyses here. So the first one is the prevalence of burnout syndrome and its associated factors among doctors in Sabah. So basically, it's to determine the prevalence of burnout and the factors associated with it. So what it was divided here into was three things: personal burnout, work-related burnout, and patient-related burnout. So the factors associated with personal burnout and work-related burnout were marital status, duration of the service, and position in the service. Next. So the second one, it shows that burnout and its associated factors, burnout and its relationship to psychological distress and job satisfaction among academicians and non-academicians in Malaysia. So here it shows that academicians demonstrated greater burnout levels and psychological distress compared to non-academicians, and non-academicians demonstrated greater job satisfaction levels when compared to academicians. Here we have the burnout and its associated factors among nurses in a tertiary hospital in Malaysia. Here it shows that occupational related characteristics such as working experience, working area, the work related stress, work schedule, and job satisfaction were associated with burnout. And the last one here, it shows that factors associated with burnout among Chinese doctors. It was conducted, a cross-sectional study that was conducted in China. So here it did explain that the findings were there were like emotional exhaustion, for cynicism, and for professional efficacy. In conclusion, these findings suggest that occupational stress is strongly related to a burnout among hospital doctors in China. So there were burnout. Most of the healthcare professionals were experiencing this burnout. Next, I'll pass it to my colleague. Okay.
Thank you, Kamini, for the excellent presentation and from the literature, or enlightened us from the literature review. So I will continue with the signs of employee burnout. So we just want to highlight here that employee burnout is real and it is not a personal problem, but it is interlinked with a workplace problem. So WHO has now considered burnout to be a syndrome, whereby if you are a healthcare manager, you would see that you have to notice that there are 6 signs of burnout that you have to see on your personnel, which is there is an increase in absences, disengagement, exhaustion, and also increased mistake or accidents, withdrawal and isolation, and also higher sensitivity. So from the survey conducted by the People's Source, 84% of the employees work through lunch hour and 29% works on the weekend. So this has really led to digital fatigue and also burnout, and employees are working very hard and some even overtime. So that is really a need for an organization or you as a future healthcare manager to take a bigger strides in employees' mental health. So we do know that some organization is already doing the efforts to help employee deal with stress and burnout, but it is still not enough. So in terms of signs of employee that we can see from this slide, so according to the Kronos and also cited by the HR leaders, signs of employee burnout could include poor performance, lack of interest, isolation, lack of concentration, cynicism, irritability, stress and anxiety, depression, forgetfulness, frequent illness and headaches, chronic fatigue, and there will be difficulty in sleeping, loss of appetite, and also they may get a high blood pressure. So from the Future Workplace study in 2016, the top reason for burnout cited by HR leaders would be the unfair compensation, The first one, which contribute 41%, and the next is unreasonable workload, too much overtime, poor management, and last but not least, the poor connection between the maybe the corporate or also the manager and also their staff, and a negative culture. So this has led to the tiredness of the people, and the sign of stress can be seen from this staff being tired all the time, sleepless night, ache and pains, high anxiety, and sometimes they could gain weight gain and inability to keep things straight, as well as anger issues at work and depressions. And according to the Society for Human Resource Management in 2017, which they have conducted the employee job satisfaction and engagement, top 5 contributors to employee satisfaction will be: the first one is the respectful treatment, the second is compensation, the third one is a trust between employees and senior management. This is very crucial, as we are actually in one particular team and we want to work together to enhance this service delivery. Next is job security and opportunities to use the skills and abilities. So in a summary, it is really important to understand the triggers and address these causes for us to improve our governance and also service delivery as a healthcare manager. So with that, I thank you. Over to you, Jonas.
Jonas, you're muted.
Sorry. Thank you, Maria. So now we'll move on to the next portion, which is understanding theories of burnout and how what are the factors that contribute to burnout. For that, I'd like to invite Dr. Dorothy.
Thank you, Jonas. All right. So burnout among healthcare personnel has been on the rise, especially during the COVID-19 pandemic. The pre and post pandemic has drenched out the energy from most of our healthcare personnel. The stress and pressure can be contributed by many factors: pressure from within the individual itself, from the employer, organization, and from the community are the probable factors that we are going to look into. I will walk you through the individual pressure. Right. Why does burnout appear and how does it develop? There are many theories to approach burnout. These are some theories that are related that I'm going to speak about. So the first is social cognitive theory. This approach characterized by giving a central role to individual variables such as self-efficacy, self-confidence, and self-concept in the development and evolution of burnout. The subdrome triggered but when the worker harbors doubt on his or her effectiveness. The second is social exchange theory. This theory approach is when the worker perceives a lack of equity between efforts and contributions made and result obtained from the work itself. The third is organizational theory. This considers burnout as a consequence of organizational and work stressors combined with individual coping strategies. The fourth is demands resources theory. This approach postulates burnout when there is an imbalance between the demands and resource derived from work. The fifth is structural theory. This approach maintains that burnout is a response to chronic job stress that appears when the coping strategies employed by the individual to manage job stressors fail. Initially, work stress will elicit a series of coping strategies. When the coping strategies initially employed are not successful, they lead to professional failure and to the development of feelings of low personal fulfillment at work and emotional exhaustion as well. Faced with these feelings, the subject develops depersonalization attitudes as a new form of coping. In turn, burnout will have adverse consequences. The sixth is a theory of emotional contagion. Emotional contagion refers to the tendency to automatically imitate and synchronize facial expressions, vocalizations, postures, and movements with those of other people, and consequently to converge emotionally with them. Usually when people work together, it is common for them to share situations and experience collective emotions such as sadness, fear, or even exhaustion. Therefore, from this theory, it is considered that burnout occurs in work groups since there are shared beliefs and emotions that are developed throughout social interaction. This burnout contagion has been evidenced, especially in teaching and health personnel, as well as between spouses, which is outside work. Thus, emotional contagion influences the development of burnout both inside and outside the workplace. Right. Individual factors such as workers' personality or coping strategies is one of the circumstances that can trigger burnout. Both personality traits and socio-demographic variables and coping strategies have been analyzed as predisposing or facilitating the development of burnout in the case of the presence of some organizational factors. Factors and their modulating effect on burnout can be positive, where they amplify the effect of social factors, or negative, where they reduce the effect of social factors. Personality influences how people perceive their work environment and therefore how they manage and cope with work demands and resources. In a study done during the pandemic in Malaysia on burnout prevalence and its associated factors among healthcare workers, I'd like to bring to your attention to the three major factors that were studied. The personal related burnout characteristics that were studied were adequacy of received psychosocial support at work, individuals suffering from some medical illness, adequacy of child support at home, working hours, and even age. Out of this, direct involvement in medical conditions or inadequate psychological support at work were at higher risk of developing personal related burnout. There are a few ways to measure burnout based on their occupation. The above can be used for healthcare workers. First is the Maslach Burnout Inventory Human Services Survey, MBIHSS. This is a 22-item survey applicable to jobs as medical professionals and also social workers. Second will be Brief Burnout Questionnaire revised for nursing staff. This is an instrument that is an alternative to MBIHSS. This comprises 21 items that evaluate the burnout syndrome itself, together with antecedents and consequences. The third is Physician Burnout Questionnaire, PHBQ, also another alternative to MBIHSS. And the fourth is Copenhagen Burnout Inventory, CBI. It's an instrument to measure occupational burnout with excellent psychometric properties. It has 3 dimensions that includes personal related, work related, and patient related burnout items. Now, these are 3 ways that we can create a conducive environment. First is interventions promoted by the organization aimed at employees. This type of intervention aims to increase the personal resources of employees to manage stresses at work. It could be done through training, strength-based interventions, coaching and guidance, creation of support groups as well. The second would be individual-focused interventions promoted by the individual. These types of actions are initiated and determined by the workers themselves and are aimed at improving their emotional and physical state completely outside the work environment. This includes physical exercise, mindfulness, self-assessment, and where appropriate, psychotherapy. And the third will be individually driven work-focused interventions. These interventions are also initiated and determined by workers, but in this case, they are aimed at improving the work environment. There are two factors or aspects that we're going to look into. First is the time management, and second is job crafting. Right. We'll just look into job crafting, where it is an individual bottom-up intervention initiated by the employees themselves, which consists of actively modifying their job by reconfiguring the way they approach tasks and negotiating the job content, allowing employees to adjust their jobs to their personal knowledge, skills, and abilities, and to their preference and needs. The next, we will talk about organizational pressure. I will pass over to my colleague, Suvarna. Over to you, Suvarna.
Thank you, Dr. Dorothy. Okay, moving on next to organizational burnout. Organizational burnout is a social problem existing long ago, a condition precipitated by prolonged susceptibility at work. And this can be addressed by several surveys, such as the Maslach Burnout Inventory, just like how Dr. Dorothy mentioned before, as well as the Burnout Measure BM, the Oldenburg Burnout Inventory, Job Stress Survey, Challenge and Hindrance Related Self-Reported Stress Scale. Moving on next is the risk factors of organizational burnout. The first one, we have lack of real possibilities to make decisions, such as lack of sense of real influence on what is happening in the organization. Terror of imposed procedures. The second one is lapses in labor organization. The first one is exhaustion because of general disorganization. This indicates how much autonomy the person has over their work. This mismatch in control reflected that the employee does not have sufficient control over over the critical dimension and resources needed for the job. Thereafter, you have two broad areas of responsibility, and finally, lack of clear, well-communicated strategy. Here, it reflects the quality of social synergy in working with colleagues, managers, and clients. The next risk factor is pressure. There are too many duties in relation to the capacities of employees. Basically, this relates to workload. The workload is one of the most discussed sources of burnout and the most obviously connected with the exertion part of burnout. The imbalances happen through numerous demands and responsibilities conducted with shortage of resources. Thereafter, you have the result motivation, pressure on results. Time regimentation, fixed deadlines. Then you have pressure related to responsibility. Finally, the pressure on unanimity and uncritical acceptance of department philosophy. Here, it reflects the individual's aspirations, motivations, and ideals in their job. The imbalance occurs when there is a conflict between the individual and organization values. Next is reasons rooted in interpersonal relations. For instance, rare meetings with superiors, limited possibility of knowledge flow. Then you have the wasting energy on exhausting conflicts, bad climate in work environment. Thereafter, you have lack of communication. Then you have politicization of promotion. This reflects the equity of social synergy, trust, openness, and respect in their workplace. The mismatch occurs when the worker recognizes and observes of injustice in the workplace. Finally, you have lack of trust. Then you have lack of possibility or perspectives of development, such as lack of perspectives of promotion and lack of possibility of professional competences and developments. Last but not least, lack of employees' basic needs of satisfaction. For instance, low level of salary, lack of salary rise, lack of sense of stability, lack of possibility to exploit own knowledge, and finally, lack of possibility to rest because of expectations of endless availability and persistent willingness to work. Moving on next, how do we this organizational burnout can cause several consequences such as pressure to perform to meet rising expectation, pressure to work at optimum levels all the time, lack of control over how you do your work. This disrupts workflow, more overtime due to staff outbreaks, fear of being laid off, personal stress, chronic diseases, eventually death or suicide as well. So there should be several measures that should be taken in order to prevent this organizational burnout. The first one is employee assistance programs have positive effects on employee well-being, such as time and anger management, relaxation, exercise, coping strategies, or positive coping mechanism. So several courses, training programs should be arranged for the employee. Next is showing concern for employee well-being. Wellness by management is important and developing support structures becomes a must, such as access on their employees' stress status and stress status. This should be a way by communicating with your employees one-to-one. Listening attentively face-to-face will make an employee feel heard and understood. This will help lower their stress and the employers as well, even if they're unable to change the situation. The third one is communication and consultation when it comes to change is important. Developing communication and consultation channels is recommended to end this. So how can we address this? We can do it by having family day, participation in decision making, turn to co-workers for support of family and friends, and building new satisfying friendship if the old ones are problematic. And besides that, give workers opportunity to participate in decisions that affect their jobs, getting employee input on work rules, for instance. If they are involved in the process, they'll be more committed to it. Besides that, consult the employees as well, talking to them about the specific factors that make their job stressful. Some things such as failing equipment, understaffing, or a lack of supervisor feedback may be relatively straightforward to address. Sharing information with employees can also reduce uncertainty about their job and futures. The fourth one is employee recognition and reward systems are required, as well as ensuring job fit for employees such as Anugerah Perkhidmatan Cemerlang and monthly best staff award or star can help them. These offer rewards and incentive is to praise work accomplishments verbally and organization-wide also can be done. Schedule potentially stressful periods followed by periods of fewer tight deadlines, and providing opportunities for social interaction among employees are needed. Last but not least, workload distribution is important, especially in the context of burnout. Reviewing recruitment strategies is a must, as well as managing staff turnover so as to not have overloaded employees. This can help make realistic work expectation by making realistic work expectation by allowing employees to have more fulfilled occupational responsibilities, as well as reasonable shift schedules and power delegation. So this can also be realistic by clarifying their expectations, clearly defining employees' roles, responsibilities, and goals, making sure management actions are fair and consistent with organizational values, as well as avoiding unrealistic deadlines, such as by making sure the workload is suitable for the employees' abilities and resources, as well as to deal with workplace conflicts in a positive way. This is by respecting the dignity of each employee and establishing a zero tolerance policy for harassment. Next, I will pass over to my next presenter, Darshini. Thank you.
Okay, thank you, Swarna. Right, moving on, I'll be focusing more on how community and environment factor can relate to personal healthcare burnout. Right. So as a health manager, I think these are the few conversations that has been picked up over the past few years, and also a qualitative analysis has been done during the pandemic. So I think we could all relate on this. For example, we keep getting patients who actually come in for trivial complaints, especially to the emergency department. I'm just running through some examples just to give you guys an idea what's currently happening in our healthcare system. So like we have patients coming in to say, I just want to check my sugar level and BP level in the emergency department, not knowing what is urgency and what is, a follow-up. And I also have patients coming in and complaining that why am I waiting too long to see the doctor, and why is it a patient that comes after me is treated first? So they fail to understand that there are patients who are at risk of deteriorating and they need to be actually addressed first, and hence it becomes viral, and then issues as incompetency of healthcare personnel comes out in the media. Although also we, like for example, we even have other healthcare personnel like lab technologists where they still need to answer work after office hours, like answering to their bosses because their own peers are unable to actually understand their role and burden. So one person takes it for the entire group. And subsequently, for example, any healthcare personnel, for the matter of fact, doctors or staff nurses, they keep, wanting to rest after a long night shift. And when they look at the rooms, they're probably not even conducive, and they just, drive back home, which is risky because this is where microsleep happen and then causes accidents. And I'm pretty sure we have all seen many accidents happening, whether it's during the pandemic or even before the pandemic itself. So next, these are the issues, and how, as a healthcare manager, how would I actually investigate and address any community or environment related burnouts among the healthcare personnel? So I think programs like non-abusive psychological and physical intervention and APPI is essential as part of their training. Like we have a lot of procedures for logbook, but probably this would be a training that we could insert into their logbooks, and this is being practiced in UK. So in this way, they will be able to know how to actually manage patients, patients' anger, patients' dissatisfaction without causing them burnout. Apart from that, reinforce expectations with training. So I think this is what that we are all lacking now, that we need to actually educate or train all the staff in a particular department on what they need to know, so that there's an equal distribution of work, as mentioned by my colleagues before, so that it doesn't fall all on one person's shoulders. And also nudge as a communication tool. This is not the nudge that the physical nudge. This is more of a nudge whereby it's an idea of using encouragement methods or suggestions whereby we change people's behavior rather than imposing laws and fines. I mean, we have a lot of laws and fines saying that if they disrespect or they behave improper behavior towards healthcare personnel, they'll be fined. But I don't think that makes a change. So this sort of nudge can actually make a difference. For example, this being practiced in UK and Australia, they have signboards, huge signboards, whereby these patients are greeted with signs like, please take responsibility for the energy you bring into this space. Your behaviors matter. and take a slow, deep breath and make sure your energy is in check before entering. So I guess that the minute they actually, look at these wordings, they themselves would know. They know how to restrict themselves by not propagating their energy or their harshness towards the healthcare personnel, because each and every one of us, we are actually doing a job. And finally, I think one thing that we should probably, as a healthcare manager, I would like to recommend this to the government maybe, or the Pejabat Kesihatan Director, the district health officers, to have awareness education for community. What is an emergency and what is not? We have services, health services everywhere, whether it's in clinic, kesihatan, or hospital, but matters as checking your blood pressure, monitoring your sugar level. I don't think you need to come to an emergency department to get it checked and then complaining that, oh, I'm waiting for a long period of time to get attended. Okay, and how do we create a conducive environment? So I think the first thing that I would like to talk about is freedom to speak. I think this has been covered earlier, like create peer support group for people to simply talk. Even if it doesn't involve your own manager, you could always talk among your colleagues. And apart from that, at every meeting, I think as a healthcare manager, I would like to reinforce the values of the organization, like any issues or stories that has happened for the past 1 month, whether it's a sweet a memory or a bitter memory. It's good to actually tell it to everyone, so that if it's a bitter one, we know that there shouldn't be a repetition of it. And if it's a good one, we would reinforce the value. And it's also a way where you'll recognize and you will be able to give some recognition to that particular healthcare personnel. And being a leader, I think we keep talking about listening, listening to your employees, but I think the bigger thing here is show up. Show up when they need you. Show up when they don't need you. Maybe they don't actually tell it out, but I think you need to show up and be able to listen to them. And that's where matters can actually be solved easily. Apart from that, I think breaks in green area, that is also environment related, whereby at least have a proper rest area, a room that has proper mattresses, so that the healthcare workers, they will be able to actually have a short power nap before they actually take a drive home. Or even breaks in green areas, you could always let them have 10 to 15 minutes break, just to get out of that whole health working place. And finally is find your tribe, and I think this should come from the employee themselves to actually find something else to do to just divert their attention from the work environment. And these are just some statistics that has been done in Italy on how work environment and related burnouts, the levels of related burnout. So I'll just focus on important ones, like which among these elements can be the cause of stress, apart from disorganized patient flow. I think disorganized patient flow is what actually brings down a healthcare personnel. Immediately they get stressed out. The noisy environment, and also inadequate or obsolete furniture. So these are the things that I will be able to focus on if I'm the healthcare manager. And also I think breaks in green areas also shows that people actually are looking forward to it. So maybe we could consider that in most of the healthcare facility. So next, I would pass on to Jonas.
Okay, thank you so much, Dashni. So we have actually tried to consolidate a lot of facts regarding what are the personal reasons for burnout, organizational reasons for burnout, and also the community and how patients interact with us and how that can cause burnout. But to measure all of this, usually in the long run, we have something called KPI, personnel assessment. So is KPI and personnel assessment something that is relevant, or how actually do we go about it? How do we know where KPI is needed and where it's not needed? So to discuss more on personnel assessment, I would like to invite Dr. Rosalie to take over.
Okay, thank you, Jonas, everybody. So I will continue the presentation with the personnel assessment as one of the possible factors for burnout and how it should be approached. So we start with why. Key performance indicators was used by private sectors to measure the performance of the organization before being adopted by the governments. Performance indicators are important for private companies, but due to the competitiveness of the local and global market. The intention is to provide evidence with their outcome-based management and to maximize profits and indirectly evaluating the success of an organization. In 2005, the process was adopted by the government of Malaysia with the full implementation in 2009 for all sectors of government services. This is part of government strategy to transform the nation into fully developed country by 2020 and fulfillment of transformation program by 2050. But the problem is that whether the assessment was put in line with reality. As unrealistic KPI affects workers' health and work-life balance, not to mention the duress experienced by the workers. Now we should compare Captain America the analogy. Now we should compare the analogy with Captain America, Marvel superheroes nominated as the top 10 leaders in the universe, which DC comic fans will definitely disagree with me. Based on the description below, anybody can guess how he was voted as a top 10 leader? So the analogy, basically, he is a leader and he leads cohort of superheroes from all the universe. His main KPI is to save the world from evils as he works with the Avengers organization to achieve that. He can achieve the impossible. He was an experiment that went right by Stark Foundation. He got no family commitment, no health issues, plenty of leisure time, and he seldom stressed out. He got Thor, Iron Man, the Incredible Hulk, and other superheroes to assist him. How do we fare Captain America and the superheroes analogy? Do we, as the frontliners who deal with life and death on daily basis, are not considered as superheroes with superhuman capabilities with no work-life balance to fulfill? In terms of designing KPI, David Farminter et al. 2007 stated that KPI should be regularly revisited and revised as the environment is so dynamic, especially from the lesson learned from the pandemic COVID-19. It will take time and effort from all stakeholders and workers to design feasible KPI. Melo et al. In 2017 mentioned that managers need to consult, discuss with their workers before drafting the KPI, guided by organization current financial situation, human resources, and workers' capabilities and abilities. But the things are the solution, are we there yet? So what are the effects of unrealistic KPI? Unrealistic KPI will affect workers multidimensionally from behavioral changes such as presenteeism, absenteeism, physically through psychosomatic symptoms such as migraine, elevated blood pressure, while psychologically it contributes into mental health issues such as morbid depression, suicidal tendency, or adjustment disorders. Even in Islam, Prophet Muhammad SAW, peace be upon him, said that 1,400 years ago about how managers should govern the workers. That is true fairness, humility, standardization, and not to put unnecessary stress to your employees. Prophet Muhammad SAW mentioned that your employees are your brothers upon whom Allah has given you authority. So if a Muslim has another person under his control, he or she should feed them with the like of what one eats and clothe them with the like of one wears, and he should not overburden them. While the book on your right-hand side, it was written on whether the 360 degrees assessment is the way forward in the future. But still, their question is it a choice or is it a correct requirement? Taking us back to the initial intention of personnel assessment in their first slide, it starts with why. So now, Abdul Aziz Yusuf, 2017, on his book, 360 Degrees Assessment from Perspective of Islam, mentioned that although 360 degrees assessment seems the future of KPI, but it is still susceptible to human errors, office politics, and favoritism. He also mentioned that the drawback still falls under the assessors and can produce more stress to the personnel being assessed. Azam and Esposito et al. 2000 also mentioned about the global resurgence of religion as an alternative to American management model that was purely based on profit maximization through fulfillment of KPI of the organization and the individuals. So what about Islam and other religions? Looking into perspective of Christianity, Buddhism, Confucianism, Hinduism, and other beliefs on the context of personal assessment requirement. This is the 4 keys to our blessing and approval. First is the one in class. Perform your task or work with sincerity. Second one is hablum minallah, or whoever improve his relation with God, then God will respect his relationship with that person. Hadis riwayat Hakim. Muhasabah, re-evaluate the work done to get the blessing from Allah. And the last one is mujahadah, perform your work sincerely and diligently for the sake of Allah. Prophet Muhammad SAW also mentioned that Indeed, Allah Subhanahu wa Taala loves when one of you works and does the job diligently. Hadis riwayat Abu Daud. And looking at the law, there is no governing law on unfulfillment of KPI with consequences of workers' dismissal or unnecessary occupational stress to the workers due to the KPI. The only law that correlates occupational stress and trauma to workers falls under the Industrial Relations Act 1996, that is Act 77. And this act regulates the relationship between employers and workers and prevention of settlement of any differences arising from this relationship. This law can be utilized under unfair dismissal for not fulfilling the KPI or constructive dismissal when workers was put under severe occupational stress due to KPI and decided to leave the organization. Melo et al., again 2017, mentioned that unrealistic KPI and occupational stress was interconnected with each other, and this actually answered the queries on whether personal KPI is one of the contributing factors that can lead to the stressful life event and personal burnout. Finding the gaps, sorry, Finding the gap. What is the gap between occupational stress and KPI in Malaysia? First, First of all, there is no special unit in Malaysia monitoring the KPI set by any organization, whether realistic or unrealistic to achieve. Second, there is no special law that governs the KPI per se in terms of possible stresses and the outcome, hence dismissal. Third one is low awareness of employers and employee about utilization and consequences of the related law. So what are the suggestions? These are the possible suggestions for the personnel assessment and how it should be approached. First, the government might be able to set up a special unit to monitor or audit the government organization KPI within the country, hence preventing unrealistic KPI and unnecessary stress to the workers. Second, practice effective communication between employers and employee in designing achievable KPI. The third one, consider the 5P when designing KPI, that is proper planning prevent poor performance. Fourth one, never accept one size fits all KPI. It doesn't work that way. Fifth, utilize the existing law in Malaysia for the unfair dismissal or constructive dismissal due to unfulfillment of his or her KPI. With this, I pass back the presentation to Jonas. Thank you, Jonas.
Thank you, Dr. Rosalie. All right, so now to wrap it up, for this personal burnout part one, to understand how to execute all of these suggestions that we have, let's look at the key characteristics that a leader requires. So, Dr. Aini, over to you.
Hello, good evening, everyone. So, burnout is one of the biggest issue that facing healthcare personnel during the pandemic. Me, myself, one of the MO that deployed to a HSB during the first COVID pandemic. So, I would like to share with you the first characteristic of the good leadership, which is influence. Influencing skill can help leaders prevent burnout in a few ways. One is that one having strong influence help leaders get their teams and other on board with a new direction. Secondly, strong influencing skill enable leaders to better advocate for their teams, securing the resources and clarity that their team needed. The second characteristic is coaching and delegation. As the workload and uncertainty rise, team members long for clarity about what they need to do and how they can best get it done. So that's why this skill have such a major impact on the reducing chronic work stress and anxiety. So a good leader coach his or her team to achieve a realistic KPI and delegate same workload to everyone. So the last one is drive for inclusion. A diverse and inclusive environment establishes a sense of belonging among employees. When employees feel more connected at work, they tend to work harder, smarter, and producing higher quality of work. As a result, organizations that adopt D&Y practices can see huge gain in the form of healthcare result, innovation, and decision making. So I pass to my colleague, Ms. Irene, for the next presentation.
Thank you, Aini.
So, how leadership can prevent their team from burnout? First of all, need to encourage their employee to take time off, which is the key for avoiding the burnout. If employees have not take time off in a while, encourage them to take time off for a few days or for a while. And secondly, the leaders need to listen to them and need to be empathetic and show support for their employees' concern. Thirdly, if the work is unmanageable, need to prioritize the work and provide a clear, realistic expectation. And at the same time, need to provide resources for their employees, such as the wellness program or employees assistance program, which need to focus on their physical and mental well-being. And lastly, need to promote a healthy work-life balance, such as sharing the stress reducing suggestion, which will allow their employees to recharge. So this study carried out to establish the relationship between burnout and the leadership style among the behavioral healthcare provider. So what we can see, the behavioral healthcare providers and employees, the association is with the poor patient and provider outcome. So the leadership style that has generally been identified as a means of reducing the burnout, it is clear what type of leadership style is more effective to mitigate or reduce the burnout. And additionally, burnout behavioral healthcare provider is there are various type of context. So which leadership style can be employed in one context may not be effective to others. Now I would like to pass over to Jonas.
Okay, thank you so much, Irene. We have covered a very big topic, which is burnout. I hope everyone's not burned out. So before we move on to the next segment, okay, we're going to discuss a big issue as well, which is patient satisfaction. Okay, patient satisfaction. In the end, we are dealing with a system where there's one end that delivers to the other end. So if we are constantly focusing on our employees, then a patient is not satisfied. If you're constantly focusing on patient satisfaction, the employees will be burnt out. So patient satisfaction, by definition, is defined as individual assessment of how we measure what the patient feels about the service that he's receiving from us, the healthcare providers. So since patient satisfaction is deemed as a valid indicator for measuring quality in healthcare, how do we managers address patient satisfaction? So for that, let me invite Bing to take over. Thank you. Bing?
Right, thank you, Jonas. Good evening, Prof. Fariza and Dr. Awatif and my fellow classmates. First of all, I would have to agree that it is important to know patient satisfaction level for us to gauge organizational performance in rendering quality healthcare services. The research has shown that patient satisfaction is correlated with important outcomes such as superior compliance, decreased utilization of medical services, less malpractice litigation, and better prognosis. In Malaysia, most government health facilities, particularly the district health offices, have and need to undergo ISO accreditation. Hence, with respect to this CBL, and as a manager of health district, we should be aware of such and shall approach this patient satisfaction issue based on the MSISO 9001-2005 requirements. Sorry. The clause 9.1 of the standard mentioned that there is a requirement for the organization to monitor customer satisfaction levels constantly in order to determine trends and opinions about organizational performance. After monitoring and measuring are done, there is a need for the organization to then analyze the result, evaluate the level of conformity to the set standard, and take action to address any risks or opportunities that are identified as part of continuous improvement of the organization quality management system. So there are two main methods to determine patient satisfaction level that are commonly in place. Firstly, the client satisfaction survey, which is carried out periodically. And then another one is through customer complaints or feedback channels that are available continuously. Another controlling mechanism on organizational healthcare quality output or process is through monitoring the client's charter indicator achievements. We know that it is a requirement under the ISO for organization to have a method to obtain, monitor, and review client satisfaction. And client satisfaction survey must be done at least once a year. And the customer or client can be divided into two types, the internal or the external clients. And for the purpose of this CBL, we shall refer it as external client, the patients. And for Ministry of Health facilities, there is a questionnaire template prepared by the Ministry of Health, which can be used by the management to conduct this survey. It is optional. Often, planning for this survey is routinely made by the Customer Satisfaction Review Subcommittee, which sits under the organization ISO committee. This subcommittee will propose the method of delivery, survey period, and presented it on ISO meeting. It is then brought up to the management review meeting, which is known as MKSP, which stands for Mesyuarat Kajian Semula Pengurusan, for approval made based on available resources, all the 3 apps, targeted number of responses, and also the target population. Survey will then be announced to the client to obtain responses, and after the survey period, a report of the survey will be prepared by the subcommittee, and it has to be presented in the review meeting to the top management for decision making and action plan for improvements. Having said that, patient satisfaction survey can serve as a meaningful way to identify gaps, develop quality improvement initiatives, and act as a balance to ensure changes in care delivery which don't negatively impact the patient's experience. Hence, this survey are essential for us to transit into value-based care. Okay, customer satisfaction can also be accessed through feedbacks received either in the form of complaints or compliments received directly from official channels such as the CISPA, also known as Public Complaints Management System. It is actually a centralized electronic channel with a top-down approach. Complaints that we receive flows down to the respective department. Also can receive complaint feedback through suggestion box, manual forms, emails, telephone calls, or even known from the mass media or social media. In government healthcare facilities, public complaints should be handled based on the MOH Public Complaints Management Guideline. And this guideline forms the basis of organization SOP in handling clients' complaint. Okay, this is a screenshot straight out from the My Government portal about CISPA, the Electronic Public Complaints Management System. Item 2 basically shows what kind of complaints can be lodged by public or even staff on respective agencies. And these are some of examples of complaint cases. There are many factors that can contribute to incidents that lead to clients' complaint. Technology, patient, work environment, teamwork, external factors. And the thing is, how do we handle complaints or feedback? Okay, first, any complaints or compliment will be verified and the source verified. Okay, either through, is it through email, surat layang, letter, phone, or even the person personally present to the office. Say it's a complaint towards a staff member, then we have to determine whether to accept or reject it. This is usually handled by the corporate communication unit, where the details of the complaint are being checked, whether is it related to the ministry, and then verify if it's unfounded complaints or legitimate with sufficient information and evidence. And then we have to categorize the complexity of the case. Okay, it can be categorized into 3: simple, moderate, and complex. And these are the criteria to determine the complaint complexity. It is in the guideline. The complexity of the complaint case depends on the nature of the complaint, whether it involves only one particular unit or multiple units or division. Is there a need to visit the site location, or and it can range from a complaint with standard feedback, which is the simple complaint, to complex cases which requires enforcement action and need long period of investigation and also monitoring, such as integrity, misconduct, medical legal cases, things like that. Okay, and for every moderate or complex complaint, there's a need to form panel of investigation. And as to how to investigate, I wouldn't go into detail here, but the guide can be found in the MOH guideline under chapter 14. It spells out the ethics of the investigation as well. Also, there is different timeline for KPIs for each level of complaints complexity. Simple case should be closed and resolved within 5 working days from the day we receive the complaints, moderate case within 15 days, and complex case within 365 days. But anyhow, public feedback for the complex cases must be made within 15 working days. Okay, this is to avoid another recurrent complaint. And based on the MOH guidelines, complaint issues can also be categorized into 5 domains: clinical, management, technical, medical, legal, and integrity. The guideline has detailed description on each of these. Suffice to know, a bulk of the complaints received are commonly on clinical, management, and technical issues, especially breakdown in communications. And now, when to respond to complainant? Okay, in the slides, point of feedback are highlighted in the red box. So the best practice is we have to respond to client complaint at least twice. Okay, first is to acknowledge the receipt of complaint and tell them investigation has been launched. It is also best to inform them expected timeline for investigation to be complete and when full response will be provided. So second response is to feedback on investigation findings and action that has been taken. So I know some of the organizations tend to miss out on this, especially when to feedback to the complainant. But usually the ISO audit will pick up on this, and the organization would normally get an OFI for it. So that's why it's very important to look into this aspect. So why do we need to analyze complaint? As a manager, we should acknowledge that each complaint holds valuable information to the quality of our care. We need to analyze each complaint in order to learn, identify concern, and decide what actions, if needed, needs to be taken. It can also be an opportunity to identify good practice from complaints. We can identify training needs for staff. We can determine problems in services. We can actually improve communication between clients and health personnel, and also improve quality of treatment and services. And also the complaint can also form a basis to review our SOP and policies. And ultimately, we want to increase our customer satisfaction. And often we consider a client's complaint is resolved after we respond to to the complainant. We like to stop at the point where after responding to clients on what we have done. Instead, we should actually go further to the extent of considering what do we intend to do. As a manager, we should ask questions like, how many times have we received similar complaints? What can be done to ease the situation? And also, what can we do to avoid similar complaints in the future? Here we can actually apply the 5W1H to analyze. Okay. In addition to all this, there is also client's charter, which acts as a tool to monitor level of services provided. I shall pass the mic to my colleague Lumin to further elaborate on this. Over to you, Lumin. Thank you.
Okay, thank you, Bing. So now I will talk about the controlling. In the Malaysian Administrative Development Circular, which is also known as the Perkeliling Kemajuan Pentadbiran Awam, Bilangan 3 tahun 1993 in Malay, Client's Charter is defined as a written commitment by the government agencies to the clients about the service provided. It is an assurance by the agencies to provide the services subject to a measurable standard of service. Usually, the standards of service are those that meet the client's need and preference. In simpler words, it is a written policy that communicates the organization commitment to our clients. On the other hand, a charter also gives a standard against which to measure employees' performance and protects employees when dealing with difficult customers. Therefore, it is important to ensure it is made known to the public as a benchmark of expected service standard. At the same time, all our staff must be aware of our own organization client's charter. In public sector, monitoring of client charters is intended for control and management within the sectors. And nowadays, service performance information is published for public review. As a manager, we must also ensure clients' charter performance are continuously monitored by organization. The performance report has to be presented in management review meeting where shortfalls and remedial action will be discussed. Having discussed about the patient satisfaction, we would also like to introduce the term patient experience to everyone. According to the Barrow Institute, it can be defined as the sum of all interactions shaped by an organization's culture that influence patient perception across the continent of care, as depicted in the diagram here. Okay, so what is the difference between patient experience and patient satisfaction? Patient experience encompasses the range of interactions that patients have with the healthcare system, including their care from health plans and from doctors, nurses, and other staffs in the hospitals, physician practices, and other healthcare facilities. While patient satisfaction is dependent on the patient's expectation with the provider or a type of service and is highly subjective. Patient satisfaction may simply measure a point in a continuum of care, hence it acts as a proxy, but is highly effective indicator of provider success at meeting the expectation of client. However, in some organizations, these terms are used interchangeably. Nevertheless, both can serve as important tools for receiving information on how to improve patient care and quality of our service. We can look at this perspective on how are we doing versus what are we doing and how are we delivering it. Okay, often patients expect fast service, accurate information provided, good hospitality, caring staff, being handled professionally, and given fair treatments. Dissatisfaction or complaints arise when these aspects are not well catered. then we will keep getting some kind of complaint over and over. So as a manager, we must be realistic in catering patients' expectation and demand. What can we do? It includes, firstly, set or convey clear expectation. Clearly communicate aspects such as organization services quality standards, like making clients' charter visible so that patients know what to expect. For example, our waiting time. Secondly, keep improving customer service standards by reviewing our clients' charter targets and act on the outcome or feedback gained from the client satisfaction surveys. Thirdly, train staffs on soft skill and invest on capacity building to ensure high level of hospitality and professional service from staff. Fourthly, take proactive feedback for continuous improvement. And fifthly, solve the root cause of issue to avoid repetitive complaint. Instead, we should engage staff to identify root cause and avoid finger pointing. And lastly, we can create an action plan for urgent complaints. Over to you, Jonas. Thank you.
Okay, thank you, Lumin. So we've discussed patient satisfaction from an angle, and now we would like to move on to indicators. How do we decide on what indicators can be used in our healthcare services for patient satisfaction? Freddie, over to you.
Thank you, Jonas. Good evening, everyone. We're carrying out for the personal assessment for patient satisfaction. Okay, regarding the patient satisfaction, it is part of the KPI of a healthcare service, and it also reflects the service quality, which is defined as the global judgment or attitude relating to the superiority of a service. And it has been mandatory since in 1998 in all hospitals in France in order to improve the hospital environment, patient amenities, facilities in the consumer sense. By the very nature of the service and the most critical dimension of the quality evaluation, it includes 5 aspects. One is tangibles, which means the physical facility, equipments, and appearance of the staff. Reliability is ability to perform the promised services dependably and accurately. Responsiveness is willingness to help a customer and provide prompt service. Assurance is knowledge and courtesy of staff, and the ability to inspire trust and confidence for the patients. And lastly, the empathy, caring and individualized attention that the firm provides to its patients. And this is the sample of the assessment. Like this was done in the community clinic of Malaysia. Tangibles, which provide enough parking space, provide enough waiting chairs, provide facility for disabled people, provide various amenities, and then their dress code. And reliability is developing as they can do the right things at the right time. And waiting time of appointment on service, whether it's too long or not. Staff keep an accurate medical records, and they understand the patient needs. And the staff is dependable. And third thing is responsiveness. The staff provide quick service to patient and always willing to help patients and give latest and complete information to the patient and show their concerns and make the patients feel appreciated. And the staff does not make to wait the patient too long. And fourth thing is assurance. It's about trustworthy knowledge in answering the patient questions politely and courtesy to the patients, dedicated in providing the services to the patient, and patient feeling about receiving service from the clinic. Lastly, the empathy, whether the staff give the adequate time for the explanation and issues, and the staff give individual attention to the patient and communicate with the patient by using an understandable language. And the staff treat the patients fairly and provide convenient operation hours that suits for the patient requirements. Presently, many Malaysian public and private hospitals, they are using various type of quality improvement certification and certifications, such as ISO 9001, both 2008 or 2015, and Malaysian Society of Quality of Health MSQH certification and Joint Commission International to meet the patient expectation through the quality health care performance. In 1993, Felcher stated that the quality performance approach to create a vision of the purpose and aim of the organization, to understand and help each individual employee of the organization, and to recognize their contribution to enhance and facilitate the quality performance towards the patient satisfaction. From now, I would like to pass the floor to Jonas.
Joanne, you can take over. Thank you.
Yeah, thank you, Jonas. So here are some common reasons that patient satisfaction surveys are conducted, and one of it is to measure hospital staff performance. Personnel assessment should encapsulate elements that are fundamental to patient satisfaction, and the focus should be on ensuring holistic patient care and management, which includes timely diagnosis of illnesses, providing quality care, and reducing unnecessary follow-up visits. And the outcomes of personal assessment should also act as drivers to improve patient satisfaction. And the results should be used to fill in the gaps, to improve work environment, to make it more conducive to provide the best patient care. To be empathetic and motivate non-performers while helping them to achieve the institution's goal in patient care. And thirdly, to acknowledge and reward the best performers so that others can learn from them as role models. Okay, so back to you, Jonas.
Okay, now for the final part of our presentation, we'd like to look at characteristics of a leader when it comes to patient satisfaction indicators. Okay, let me invite Khalila. Thank you.
Okay, sorry for the lagging because of internet. So, right. Okay, thank you, Jonas. So in terms of patient's satisfaction, what are the key characteristics that needed in a leader? So the first one, if a client is upset about an experience with an employee or simply the situation at hand, it can be easy to get defensive and respond to their complaints with the same tone. So the situational theory of leadership, which is the Hersey-Blanchard model, suggests that no single leadership style is best, and it depends on which type of leadership and strategies are best suited to handle an issue. According to this theory, the most effective leaders are those who can adapt their style to the situation and ability to respond quickly to the changing environments and develop the strategies suitable. So the first one characteristic of a leader is ability to adapt to any situation. Second is a leader need to be attentive, have the openness and empathetic feelings towards both client and the staff, ability to accept any complaints and feedbacks from clients, as well as encourage open communication with both clients and involving staff. Why I use the term clients? Because patients are not only in terms of patient methodology, we call it client. So there are few leadership behaviors. One of it is a democratic style, which describes a leader as a person who involves the employees in decision-making, delegates authority, and use feedback as an opportunity for coaching employees. So in response to a feedback or complaints, a leader must have the skills of how to find the cause and the best solutions. It requires decision-making skills in choosing the best alternative to resolve a problem. For example, using the 5 why steps, get a team together, define a problem, ask why, learn when to stop, and then so this ask why, we normally use 5 whys, which are the why patient satisfaction is low, why patient complain, the staff speak harshly. So why the staff treat a patient harshly? The staff is too tired or have problems at the workplace or with other staff. So why the staff is tired or emotionally unstable? The staff is overburdened with a workload or long working hours. So why the staff is overburdened? The human resource is not enough to cater the increasing demand for healthcare services and the number of patients. So why not analyze the work schedule or the clinic hospital appointments by doing staggered appointments or rotation of staff? So the leader can think of the corrective actions and then implement them. And last but not least, to monitor the implementation and audit the corrective action have been taken. So this is my slide. So Victoria will discuss a bit on the leadership. So over to you, Victoria.
Thank you, Kalila. Right, so drawing from the traits of a leader and trying to solve our case for today. So speaking as a manager, I realized that I'm leading the team, and ideally my team trusts me and I'm responsible for the decisions leading to the organization's success and failures. And so the patient experience is a direct reflection of the organizational culture established by me. And I know the organization which focuses on procedural excellence only but settles for mediocrity in service will see a result in mediocre patient experience. And as demonstrated by figure 1 over here, in between leadership and patient experience, you can see the goals, staff engagement, and culture. Hence, I must make a decision with patient safety and experience in mind. And so we move to goals. So I should establish a strategy to improve patient engagement and focus on service excellence to increase patient satisfaction. So I should clearly state in writing the direction of change, set expectations, and provide instructions for engaging staff and helping them meet these expectations. And all team members, regardless of who they are, need to commit wholeheartedly to these goals. And it's also up to me as a leader to inspire my team. So I can't be projecting a vision of excellent patient experience without holding the team responsible for ensuring that happens. Team members should feel like they belong and are valued as individuals. I need to emphasize the importance of each person in the team. And I do this by recognizing, encouraging, respecting, teaching, and empowering the team. I follow up with them if they don't follow protocols kindly, but I also highlight and celebrate exemplary behavior. And finally, I should create a culture. An organization's culture is the lens through which staff see patients. And this culture is also directly related to the attitudes and actions of staff and thus patient experience. And I would also encourage team members and check on them periodically to raise morale and reinforce a purpose. So you see what I was doing there. I was being a transformational leader. So there's a difference between transactional leaders and transformational leaders. Transactional is when you see your interaction with the team as just purely transactional, an exchange of one thing for another as long as the job gets done. And transformational, on the other hand, is when each team member is recognized for the specific expertise they bring, and you provide them with a sense of purpose and autonomy and encourage them to be the best versions of themselves to achieve a goal. So to solve the problem that we have on hand here, I need to be a transformational leader to partner with team members to achieve mutual goals for better patient outcomes. And just to add, it's also very important that the organization assesses me as a leader and also the future leaders of this organization, assessing the degree to which I practice transformational leadership. And it would also help if the same leadership education is provided to everyone to promote the culture through the organization. And this will improve practice, patient care, and also patient satisfaction. I'll pass the floor back to the moderator.
Okay, thank you so much, Victoria. Just take control. All right, so we are at the end of our presentation. So to answer our question today, we believe that a team is as strong as its weakest link. So for us to address these issues in our organization of 3 million people in this district, we have individual pressure, organization pressure, and also patient satisfaction. And we're presented with common problems with uncommon solutions. And our health system comprises of many blocks, from the governance, human resource, financing to the information part. But as a leader, our goal is this: to ensure that the team leadership is present, whereby there's concern for people and there's also concern for the task related. So as a manager in the 3 million district health environment, what are we answering the questions here? First, burnout. Do we know how many of our staff is burnout? What are the symptoms that we are looking at, and are we actually assessing these symptoms? Organizational change. Are we preparing our staff for the transition from pre-COVID to post-COVID, as well as patient satisfaction? We know that this patient satisfaction is an indicator for good performance of a healthcare system. And why is it that before the pandemic it was detected, but it's still not settled after the pandemic? So we've discussed and planned and organized our opinions today, and we're going to open the floor for discussion. And thank you so much, everyone, for listening to our presentation today. So, Dr. Awatif, I'd like to pass it back to you. Thank you.